I am Dr. Professor P.C. Manoria, Executive President, 4th World Congress, Cardio, Kidney, Metabolic Medicine, 18th, 19th April at Hotel Leela, Mumbai. And with me is Dr. Sunil Gupta, President-elect RSSDI and a globally renowned diabetologist. So, Dr. Gupta, we are amidst an era of revolutions in diabetes. The first revolution was kicked off by SGLT2 inhibitors and GLP-1 receptor agonists, which changed the face of diabetes management from a mere glycemic control to cardiorenal protection. Then we have the second revolution of new anti-obesity medication, SEMA and TIRZA and others in the pipeline. Then we have the third revolution of technological and innovation, and the fourth is an artificial intelligence innovation. But the basic fact remains diabetes in India is reaching alarming and epidemic proportions. We have 101 million patients of diabetes, 136 million pre-diabetes. So what can be done to reduce the number of these diabetes? Otherwise, every time we hear the near status growing, and they are reaching colossal figures.
I fully agree, Dr. Manoria, sir, on this point. I feel one very important aspect which is less likely to be covered in most of the meetings. When you talk about primordial prevention of diabetes, I feel pregnancy is one thing which is at most important. Now, someone has said that we have a concept of the fetal origin of adult diseases. We call it as fetal origin of adult diseases. Now, this particular concept has come from Australia, from Barker, and then we have understood that if you focus on pregnancy, you see, most of the planning or the programming of a person when he is intrauterine, that it gets over when they're in intrauterine phase. So intrauterine environment have its imprint on the baby's overall structure, physiology, and they ultimately become more prone to have diabetes, blood pressure, obesity, hypertension, coronary cardiovascular disease in their adult life. So if we focus on pregnancy, the early detection of mildest form of hyperglycemia in pregnancy to be focused. That's one thing. Every woman, almost every fourth woman in our country, sir, now is having hyperglycemia in pregnancy. Almost 85% will be gestational diabetes, which appears in pregnancy, disappears after delivery. Another 15% will be pre-existing type 1 or type 2 diabetes. They are becoming pregnant. In both the situation, if the baby inside the womb is getting exposed to the poor intrauterine environment of hyperglycemia and maybe some other mixed nutrients, if you focus on that, we can certainly achieve, and this hypothesis has been now globally accepted, that the intrauterine environment is being focused, diagnosed, screened, diagnosed and treated in a most effective manner. And if you have a good neonatal outcome out of it, the chances of developing diabetes to the offspring, which is going to become adult in future, will be certainly much less versus if you don't treat it. And this data has also come from a comparison. It's not just, we have the evidence that if there are two babies, same genetic risk, first baby and second baby, if the first baby was when she was not GDM, second baby, the mother was GDM, the chances of having diabetes, obesity and non-communicable disease to the second baby is higher than the first baby. And that is why we have to be, possibly that is one thing which you and me need to now focus more aggressively when we talk about primordial or primary prevention of a disease like diabetes, hypertension, obesity and cardiovascular disease.
See, tight glycemic control is very important in pregnancy. What is the period which is of immense importance, and how do you assess glycemic control in pregnancy?
Sir, when we talk about tight control, there are two subsets of patients. One who is a known type 1, type 2 diabetes, we have to focus on preconception counseling. We have started from RSSDI, Research Society for Study of Diabetes in India, what you have just introduced to me as a president-elect. We have started with a new concept of fitness for pregnancy. So we know that you also have introduced that we have 101 million people with diabetes and 136 million people with pre-diabetes. Pre-diabetes in non-pregnant state is diabetes in pregnancy. So all these women of 236, almost every fourth woman above 18 years of age are likely to have some kind of hyperglycemia in pregnancy. So if they are known, they should achieve their targets much earlier. Before getting conceived, their fasting should be less than 90, postprandial should be less than 120, HbA1 should be ideally less than 6, if possible less than 6, if not at least less than 6.5. If it is type 1 diabetes and there is high risk of hypoglycemia, you should try to achieve less than 7. Preconception, before getting pregnant, An unfortunate part is, sir, you also know it, 90% of the pregnancies are unplanned pregnancies. So we have to reduce this unplanned pregnancy, improve the preconception counseling approach and the concept in the society, so that every woman should plan it and then do it. So this is one. Second is those who are GDM. So you have to screen every woman in the first trimester with the simple glucose challenge test or oral glucose tolerance test. 75 gram glucose, irrespective of you're fasting or non-fasting, Government of India has endorsed it. Take 2-hour test. If it's more than 140, diagnose it. If you want to use some other criteria, you can do that, but do this. And if they are more than 140, diagnose them. Even 120 to 140 is borderline case. Even they should be also treated. Then if you address and try to, and as the pregnancy advances, the blood glucose goes up. So you have to treat it. Either 70% will do, this pure GDM will do well on diet therapy only. Nothing else will be required. 30% might need insulin therapy or the metformin, whatever is the choice and applicable to the women, and then you treat them so that you have not only have to have a neonatal good outcome, but also have the good future of these babies who are born to these mothers.
Which anti-diabetic medications can be given safely in pregnancy?
Sir, insulin is the safest and gold standard for pregnancy. Insulin doesn't cross the placenta. But all other oral drugs, they will cross the placenta and will enter into the fetal circulation. That's why in India, we have approved metformin. DIPSI has approved it after 12 weeks. Government of India has approved it after 20 weeks. Recently, European guidelines after the MITI trial have approved use of metformin from the preconception till delivery, unless and until it is contraindicated. The only contraindication for metformin, which everyone should remember this, is if you have some situation of placental insufficiency, preeclampsia, IUGR, oligohydramnias, polyhydramnias, multiple missed abortions, or past history of macrosomia. In such patient, again, insulin remains the drug of choice.
So thank you, Dr. Gupta, for the excellent takeaways.
Thank you very much.